Hi everyone, thanks for joining us on this hot take tonight on the National Cancer Plan, which was published just yesterday. So I'm joined with some really eminent people from the land of cancer, from oncology, to discuss this. If anyone knows if this plan is of any substance, these are the people to discuss it with. So I'm just going to introduce them one by one. We've got Gordon Wishart, who's a Chief Medical Officer at Check for Cancer and visiting professor of cancer surgery at Anglia, Ruskin University. We've got Mark Lawler, Professor of Digital Health, Queen's University Belfast, and Chair of the International Benchmarking Partnership. And we've got Wimslow's very own Professor Pat Price, who is Professor of Oncology at Imperial College London and Chair of Radiotherapy UK and co-founder of Catch Up with Cancer campaign. And this podcast is in partnership with Radiotherapy UK and Check Up Cancer campaign as well. So just to give people context out there, so this is, for all our patients, for all the people watching, cancer is really common. It's going to affect 1 in 2 of us. And we have 970 new cancer diagnoses every day in England alone. So it's something that affects us all, and it's important to ensure that the UK's cancer services are the best they can be. So Pat, where are we up to?
Well, we've got a new national cancer plan.
Which is good, right?
It is good.
Yeah.
Now, remember, we've had national cancer plans since the mid-1990s.
Right.
And we get them renewed every 5 to 10 years.
Yeah.
And some have been really very good. So we haven't had one since 2015.
Wow.
And what's important is that actually we very nearly didn't have another national cancer plan because we had a little bit of a sort of, perhaps we'll have a multiple diseases strategy.
Yeah.
And then we fought hard. And in fact, Mark, you were the one that had to go to the select committee and bash them around the head and say, you need a national cancer plan. So you're really big in the international field. So tell us, why do we need a national cancer plan?
Yeah, no, thanks very much, Pat. So I presented to them, it's actually over 2 years ago, if you remember now. So it's the 9th of January, 2024. I presented to the select committee. I know it doesn't seem like 2 years, but it is. And I mean, I think, on the day, it was very much clear that they got the message on the day. I said, international best practice is to have a consistency of cancer policy, which involves having a cancer plan. One leads to the next. I used the example of Denmark, where they were in the years 2000 were pretty much the same as us, very much at the bottom of the league table. They looked at that, they said, what is going on here? And they decided to do something about it. So they introduced a series of cancer plans that built on each other. They also amazingly got all of the political parties to agree, no matter who was in power, they would still deliver the cancer plan. And then critically, and Pat can comment on this as well, in relation to radiotherapy, they looked to see how many radiotherapy machines do we have per million population. And they found they had the lowest in Europe. So then, and so they had poor outcomes, lowest number of radiotherapy machines in Europe. Then they upped their game. They got to the stage of having the second highest number of radiotherapy machines. And hey, presto, their outcomes got better.
So that's Denmark, which was languishing at the bottom of the league tables. And did you say that that's where we are right now?
Yeah, unfortunately, it is. We're, if you look at it in terms of comparing, with, we're like Estonia or it's just not
Bulgaria.
It's not great. It's very disappointing, and it's the disappointing thing is if we'd gone the way Denmark went in the year 2000, we wouldn't necessarily be top, but like Denmark aren't top, but they're the most improved in that period of time because they're coming from a low base, as we still are. We have improved somewhat, but we haven't improved any that were like what we need to do.
No. And how does that translate into real life stories here in the UK? Because I can certainly tell you stories about people who have, we've done all the right things. We've caught their cancer early, but then there's a delay in getting treatment.
Yeah, and I think this is what I think we're all worried about, because when we've moved over the last 30 years with cancer plans, we've moved to specialised people doing it.
Yeah.
We've moved to multidisciplinary teams. We've moved to the importance of the 62-day wait, importance of early diagnosis. All these things are great, but we've kind of lost the plot. And I think really our best measure of how to improve cancer survival is the 62-day wait, in terms of you've got to get your treatment on time and again, all countries, you've got to do that. So that's a key pillar of it. Of course, all the other things, stopping smoking, don't get cancer, all these things, that's great. But, Gordon will know early diagnosis, but also early treatment. So that's the core of it. But our measures of that have been decreasing, sadly, since NHS England around 2013, 2015,
Gosh.
slowly decreasing, and we can go into the reasons. And then, of course, COVID. Absolutely fell off a cliff. And I think, Gordon and Mark and I, Gordon, we've been writing in the Lancet, haven't we? Bring it to the attention that this falling off the cliff. So we're really down to a sort of really low, and we can't seem to lift ourselves off the bottom of there. So you've got this problem, as you say, you may set them up, but they're not getting their treatment on time. And that is the bulk of the problem. Of course, plans have got to be talking about, prevention and all these other things. But at the heart of the UK problem at the moment is the NHS getting people their treatment on time. Gordon, I know you've been writing quite a lot with us in the Lancet, oncology and things. How do you see that sort of poor treatment in the cancer pathway at the moment? Because I think that's what you're seeing for patients.
Yeah.
Yeah, I mean, Pat's absolutely right. We are a late cancer detection country, and that's really sad. And you're right that the 62-day target has just got worse and worse. I mean, far less, discussion that we haven't really reached that target for the last 10 or 11 years, I think. And I just can't see how we're going to, with the measures that are in this new cancer plan, I can't see how we're going to attain it in the next 3 years. And a lot of that's to do with the fact we just haven't kept pace with the increasing population, and of course a population that's getting older, and requiring more input. So the whole infrastructure, Mark was talking about, you know Denmark having far less radiotherapy machines per head of population. Well, if you look at our CT and MRI scanners per head of population, we're almost the bottom of all Western countries and right down at the bottom of Europe. So it's really disappointing to see that, apart from some increased funding in the new cancer plan that will go towards creating, more scanning slots, and presumably will buy some additional scanners. That's really the only new funding that I can see in the whole plan. And clearly we need far more than that, because these scans, as you know, Pat, are so crucial, not just for diagnosis, but for treatment planning as well.
So I was thinking, in terms of, if we're thinking of hot takes, because the plan has come out now, which is great. What's our thinking? For me, I must say, we were down, Mark and I, in Parliament yesterday. There were patients with us. We took a petition to Downing Street. In fact, I met briefly with Wes Streeting. I think, for me, what's coming out, I do think the Secretary of State, Wes, is really committed. As a cancer survivor himself, he really gets it. And I've only met him and probably Jeremy Hunt before, who, because of he's been attached with cancer in his family, that there's this next level of they really get it, which I think is fantastic. Great. So we've got a Secretary of State that viscerally gets it, which is great. I think then we've had the Department of Health now merging with from NHS England. I think they've worked hard for 2 years, but I think their job was they put out a consultation. Okay, so they got 11,000 responses.
Wow.
Now, I
Who were they
think,
consulting?
well, anybody, but what worries is that, did everybody write in because they want to say this is awful, whatever? So it doesn't know, but apparently it was made up of there's 60 cancer charities, there's members of the public or whatever. I think they had to wade through that.
What about the clinicians?
They did speak to clinicians, but I'm not sure. Well, we'll come to it. I'm not sure it came out, but that's how it arose. But I get the feeling, talking to them, they presented a plan with a range of things, and then it goes to somebody else. I wonder who the somebody else is, presumably the Treasury.
Yeah.
And it then comes back with what we can have. So that's how it
Right,
arose. So
right.
honestly, I think really good intentions. But what do we think of the actual plan? What is our big takes on the actual what's come out in the plan? The headlines were, again, the PR around the headlines was a little bit odd.
Yeah.
They said 75% of people will, when they're diagnosed by 2035, will survive more than 5 years, which is essentially recycling the target of early diagnosis, which they said in 2015 was going to move from 55% to 75% by 2028. Okay, missed that target. So let's shove it in now till 35. That was a headline. Second headline, which is the most crucial one, suddenly by 2029, they're going to have all the 62-day targets met. It's a miracle in 3 years.
I
That's
mean,
great.
That's a big
completely. I
ask,
mean,
isn't it?
yeah, I mean, that really irritated me, to be perfectly frank, because I looked at it, and at the moment, 3 out of 121 cancer trusts in the UK have made the 62-day target. So what you're
Wow.
talking about is, in order to reach the 85% that you're aiming at as the target, you'd have to improve something like 332,000%. Like, it's just as, like, it's not
Right.
a number that we can even contemplate. I just don't know. Yeah, 3,327% improvement it would need to be. That's what worries me. There's things like slash and, do this, and, but there's no detail. So there's great aspirations. Some of them, I think, as Pat has said, and I've said in that example, are just not realistic. I think we have to forget about being the best in the world, as been said in it. We're not the best in the world. We're actually very low down the table if you look at for many different cancers. So stop saying we're going to be the best in the world. We're not going to be the best in the world in the next 10 years. And what we want to do is consolidate ourselves. It took Denmark 20 years to actually get from where they were to where they are now, and they're still not top of the league. They're the most improved. So, I wanted to see more detail in the plan, or how they were going to do things. At the moment, it's more like a strategy at a very high level with some great aspirations. And I agree with Pat. West Reading is definitely determined to do it, but that's not what we wanted at this stage. I didn't wait 2 years from presenting it to the House of Commons Select Committee to get this, to be perfectly frank.
Wow.
And Gordon, I was thinking from the surgical point of view, I noticed AI talked about a lot, sort of genomics or whatever. Surgery wasn't mentioned a lot. And I note the aspiration for surgery is to have, it's mixed in with the normal non-cancer ones, to have 90% of operations, laparoscopic operations robotically. Is that the answer to your problem in surgery in cancer?
Well, I mean, that's maybe a really good idea. I mean, I like the idea of robotic surgery. It has less complications from the studies that have been published so far. That means patients leave hospital quicker. There's probably a productivity gain to be made by doing that. But I don't think that should be in a national cancer plan. It's much more important that people are operated on quickly rather than the method that they're operated on, I would say. And I think there's nothing about workforce in here. There's all these things that are going to be done. Can you imagine what our clinicians are thinking? They'll be tearing their hair out, if they've got any left. That it must be so frustrating to see who's going to do all this. Well, actually, it's this,
AI,
workforce
AI is
that's
going
all.
to do it. Yeah.
AI is,
digital
AI
can't
might
help.
help in some places,
Yeah,
certainly
exactly.
in diagnosis, but actually this is going to fall to the current workforce. And we know there are huge, shortages of clinical oncologists, of radiologists. As Mark said, great ambition and aspiration, but
Yeah.
little detail. And without
And
that,
Yeah, and do you think, I'm just a bit worried also that the workforce is on its knees really since COVID and all this saying, and they were really looking forward to this cancer plan. Do you think they might just think, oh, there's nothing, we're not even recognised as the problem? Do you think they might just think this is just too much now?
I think it's possible that people that are getting close to retirement may just say, do you know what? I've had enough. And the other thing I was thinking earlier today is, and I know we can't hark back to the old days, but when cancer plans were first introduced, at that time the consultant workforce I think we're quite prepared to work a bit more,
Yeah.
to put in the extra mile, and that goodwill has gone now.
Yeah.
And so there's no spare capacity within our
No,
current workforce.
I was reading all the stuff about, more of the care going into the community, but again,
Yeah.
as ever, there's no
Who's going to
funding
do
for
that?
it. We are on our knees.
No, I mean,
And
exactly. Who's going to do that? I mean,
Yeah.
language is very instructive, I think, in these things when you look at plans and aspirations. So,
So
surgeon,
overall, yeah, go on.
surgeon, the word surgeon is mentioned once in the plan.
Oh my
AI is mentioned 33 times. Genomics is staggering 89 times. Data is fair enough, 104 times, but data would come into a lot of things. But like I'm a chair in translational cancer genomics. Even I think that's overplay in relation to genomics. So it's actually really worrying if we're sort of saying we're going to sort of use technology to get ourselves out of this crisis. Technology can help, and certainly digital can help in relation to freeing up some time. But if we don't deal with the workforce, I would agree. We're going to have a significant problem if we look at pathology, if we look at radiology, if we look at surgery. There are big challenges there, and it's been highlighted that particularly in the UK. So I was involved in the European Cancer Organization publication where we looked at what was the problems in relation to cancer workforce in different countries in Europe, and it was most acute here in the UK. So that should have been what they were looking at. That's what they should have been saying. I agree with Pat. I would definitely be worried that people would say, we were looking forward to this. We presumed there'd be something about workforce in it. There isn't. It's all about, it smacks of smoke and mirrors, to be perfectly frank now. I know I'm saying.
And do you think it's got anything to do with, they've put all these targets for 2028, 2029. Do you think it's anything? I mean, the cynic in me is kind of, you guys are being very charitable about this, but it's the plan is all, there's some bits of it which are laughable and seem to be there just for political spin. Am I just misreading it? Misinterpreting
I
it?
think a lot of the feedback we've seen from people, particularly actually, if you look in some of the comments online from actually members of the public, they're just thinking this is just another load of good news stories that are not going to mean anything. And I wonder then that because we've got to get the public on board as well.
Totally, yeah.
But in some ways, what worries me is that there's a lot of people, we've done a lot of work ourselves on this. You've had international leaders in the field. We have meetings at St. George's House, some really good thinking behind this. Even when we met the first time round, and we were talking about that integration of primary care into the plan. Was there anything in there from the primary care, or you were just the guys that were going to actually work?
Absolutely, yeah. This is how you're going to do it cheaper.
Yes, you're cheap. Cheap data, are you? Yes.
My worry is who were they talking to? Because it's certain were they talking to us. I mean, I had one very peremptory talk with somebody who knew nothing about cancer. That was a full consultation with me.
You're joking.
That's all I've had. I didn't see any copies of the plan. So essentially, it's hilarious. We presented the data that actually caused the minister, as a Secretary of State, to decide we need a cancer plan. And then I had one conversation with somebody who didn't even know what cancer was, hardly, as far as I could tell, from some sort of company.
And this is the National Cancer Plan for England. And, the experts, people who've written in the Lancet, who are renowned in their field, are telling us the truth here, that actually there's not much to this plan. And I think, we've got to kind of wake up as a nation. And, we're certainly going to be telling our patients, look, you guys, you need to start waking up to this and perhaps writing to your MP about it. And
I think that's a good idea.
This is our cancer. These are real patients, real suffering. Our mothers, our brothers, our sisters, when they get cancer, there's no service there for them that's going to treat them in a really effective way that they deserve. So I really,
And I think it takes it to the next level, because I know people criticise the government for sound bites and should the pubs have extra VAT, and and I get all that concern, but cancer is a next level of worry. This is serious. Actually,
it's a crisis.
This worst cancer crisis of our lifetime. And the only thing that's encouraging me, because they've put their stake in the ground, going to meet the targets by 2029. Good. At least that is something that we can keep going on. I know the BBC just lately have told me they're going to put a tracker and they're going to keep an eye on this, which is good. But in terms of talking to people, because I was a bit astonished, Mark, that I'm actually shocked that you haven't been integrating this. When I think most people agree the good cancer plan was 2000. What was the essence of that? It was a Labour government as well. They said it was a cancer czar reporting centrally into the Prime Minister, could cross. The main thing was independence. They weren't being told by the NHS what to do. It was totally, and who started the International Benchmarking Committee? The cancers are then. And so now we've got to all this time later, no independence, no oversight, and the International Benchmarking Committee will talk to you once, perhaps. So I suppose, now, do you think that it's about is it a bicycle shed moment? Because I wonder, how did we get like this? Because there is an argument. It's like if you're in a committee, you've got two things on the agenda. Let's talk about the nuclear reactor. Well, nobody knows about that, so we'll solve that in 2 minutes. Now, the bike sheds, well, we all know about the bike sheds, and let's have a really good discussion on that. So have we sort of fallen into this trap? I wonder if you're going to have to respond to 11,000 consultation, what do you do? Who shouts the loudest? Who shouts the most?
Really worrying.
And I'm a bit worried that all the cancer charities seem to have welcomed this cancer plan. What I'm worried
One of the things
is
that
that
really disappointed me, Pat, was when we held the St. George's House consultation. We brought in people from all over the world with their experiences and what they'd done well and what they'd done badly. They were very honest. They provided that. Did anybody from the Department of Health turn up for that? No.
we did invite them, and it was the tube strike, and it was an online meeting, and they said it was a bit late notice to come. But I did send it to them afterwards. So, but perhaps that was a bit late. But in fact, what's been great, the international community are really happy to help here.
Yeah.
Because because to be fair, we say the 2000 cancer plan was great, but they had money. They weren't in a mess. The NHS hadn't fallen apart. It wasn't post-COVID. They had less patients and they had less costs, and the workforce weren't exhausted. And even then it was tough. Now, I think, to be honest, I think this is one of the biggest challenges. And I think this needs every single brain in the country working on this, and as much international advice to seriously get our way out of this.
No doubt about it. This is a crisis.
Effort.
I mean, the one good thing I did see in it was the whole focus on rural and urban. I thought that was, that was sensible, and looking at training people who would go back into the community. That was something that I thought was thought out. A lot of the other things were simply, high level and aspirational, which is fine, but that's a strategy. That's not a plan. A plan is, here's what we're going to do, and we're going to be held to task for this, and this.
So should we have a bit quick hot takes on what were the good bits?
Yep.
Let's leave the but we can come back to the bad bits. And the gaps? What were the good bits? So the concentration on rural communities, that was great. Gordon, for you, so I know
that's where they listened to us, because we provided a lot of data that the urban-rural divide. So that was great, and it's something tangible. I think it's something that people recognise as something that needed to be done in the UK, because we've seen that there are significant inequalities depending on whether you're rural, urban, and coastal. And it follows up on what Chris Whitty said in his report in 2021. So that sort of made sense to me.
a focus good. Gordon, because I know you were involved in a company that actually really specialises in fast and early diagnosis. So what do you think were the good bits in there for you?
I spent a lot of time reading the report yesterday because it's important for me to feed back to the business and what I think. I have to be honest, and I think Amar is absolutely right to be highly critical of this. I can't see anything really very good in this at all. And we can ask for all the advice from international partners. I think our report that we produced after St. George's House was excellent. Now, that was October 2024, I think. That's what we should do. But we can have the best ideas in the world. That this government, like previous governments, has chosen not to fund this. They've made decisions that funding has gone elsewhere. We can't do anything without ring-fenced funding. And I agree with you. We do need to bring back a cancer czar. I think, we said that. We've talked about that several times because you need that independence. And I think without those two things, I think we'll struggle to produce anything. You need a team of 20 or 30 people to produce a report like this, not 11,000 people. I remember working with Mike Richards back in 2000 to try and take the 2-week wait that had worked really well in breast and was part of a committee that said, how can we now bring this out to the other cancers. And that's the way you learn. But it does need funding. Because as we said earlier, the goodwill has gone. So I'm afraid I'm feeling quite negative about this. And certainly, you know, the the private sector is going to have to step in and help do some of these things. But it would be much better if it was funded internally right from the start. And I know when we were at St George's House, we thought of some quick wins that would make a difference. You know, rolling out the lung cancer. You know, bring the lung cancer screening program, roll it out much more quickly. You know, reduce the threshold for fit testing for bowel screening now, not by 2028. You know, we understand that they're reviewing prostate cancer screening at the moment because they did the assessment wrong in terms of the benefits. Now that might come through, but you know, and there are opportunities to, you know, improve breast cancer screening for women with dense breasts. There's great research that shows that, you know, extra imaging, MRI, contrast enhanced mammography can pick up lots of extra cancers. So those 4 cancers are nearly half of all the deaths from cancer in this country. That's where I would focus our thoughts. Rather than trying to do too many things, let's try and get some quick wins, improve the survival, and then get some momentum going. But it does need funding.
No, but you're right in terms of Gordon getting some quick wins, and that, you know, Denmark didn't do everything in one cancer plan. So this is the, you know, we have to think about the short game, but also the long game. The other thing in relation to funding that's really starting to annoy me is people are saying to me, "Oh, we have to spend money and more money on defence." So my reply is to them, "What about defence against cancer? Why aren't we spending more money on that?"
Yeah, absolutely. That's a great way to look at it, Mark.
And do you think also it's putting people into impossible choices? Because again, talking about some of the money that's for treatment, they've said actually that's in the elective budget. Oh, well, we've given billions for the elective budget. So our trusts, have they got to decide, do I spend the money on the roof that's leaking, the patient with cancer on time, or my hip operations? That's an impossible situation to put people in. You can't do that. It's interesting also about how did it get to this thing? I remember one review that was written up about what went right with those 2000 cancer plans. And, you know, they said it wasn't through committees and representative bodies. They said they got the best brains in the room and just thrashed it out till they got there. And kind of perhaps you get to do that. I'm a little bit worried we haven't had any positives. Amar, are there any positives in that?
I think the very fact.
But urban
that
rural, I
someone
think,
is-
is a positive.
You're rural. It's not rural.
So, I'm glad that they're actually looking at it and
Yes,
that
there
there
is
is a
a
plan.
Yes.
I think that's as far as I got, because the rest of it is all highfalutin ideas that sound really good in a press release at certain times of the year. But I think all of us agree, don't we, that there's no meat on the bone at all. And quite clearly, there is no funding. We are, you know, the NHS, not just in the cancer domain, it is totally underfunded. And, you know, we do a lot with AI and tech and all the rest of it. And
Yes, you're really advanced with tech. You know, you're
Absolutely.
into tech, you know.
but that's not going to save us from this cancer crisis. That's not going to put the people down on the you know, the coalface to treat the people. And we know that the rates of cancer are going up as people are getting older. We know that we can predict how many people are going to get cancer in the future, and we are just not ready. We weren't ready for the pandemic, and I'm telling you now, we are not ready for the looming cancer crisis that's we can all see, that all people in the know can see.
And how does that affect your patients? Because you get the patients here now.
Yeah.
You've got patients coming in the door now.
Yeah.
So because the hospital is clogged up, nothing
Yeah.
how does that? Because I remember you were saying once you're almost having to treat the cancers yourself because you can't get through and people are phoning up appointments. How is it for your, the good people of Winslow?
Yeah, I mean, we do our best, and we've got a triage system where we try to give attention to those most in need clinically. Cancer is right up there, but you know, we are so overwhelmed with so much other stuff that the government seems to think is a good idea to move out, which it is a good idea, but you need the workforce, you need the funding to pay for it. You know, we are on 5% now of primary care is on 5% of the total NHS budget. And then the NHS cancer plan comes out, which, you know, it says that, yes, we should be doing more to diagnose it earlier in the community and actually do more treatment in the community, but we're not going to be able to do that on 5%. And someone needs to wake up in government and actually, have an honest conversation with the public and say, how are we going to fund this all? And be honest with us. If we're going to have cancer treatment which is on par with Estonia and Bulgaria, then say it. But don't try to spin your way out of this, because that's, I think, what people are guilty of right now.
Do you think also there's another elephant in the room about what it is like in the NHS at the moment? Because I found, I don't know, I'm very old. I remember I've been a consultant 37 years. When I started, before NHS England, you had responsibility, you had to develop things, the management were there to help you do what was right for patients. NHS England starts, and suddenly it all becomes, you're there to do what the management says. And then it's got more and more, so people are more and more almost can't do anything. And I've so often said this, it's people are sick of being tired of being told what to do by people who don't know what to do. And so instead of, and in fact, if you were in Marks and Spencer's now, if you were somewhere organizing things, you would want to empower every single person on that shop floor to do something, get something done. And it's about, what are the blocks? There is blocks all over the place. I know, again, in businesses, they send people down. What's your problem this week? How can I solve it? Whereas there is nothing there in the clinical workforce. We can see things you can solve tomorrow, but you're not allowed to do it. You're told what to do, and there's collecting data, and there's all these things. Whereas, so you could completely flip it on its head and just basically empower the people, and you could solve a lot of those problems locally. But the bureaucracy, it doesn't help. So my feeling is, unless you get rid of that, we will be here in 2029, and nothing will have changed, because you have to flip it on its head and empower people. But that's getting to the heart of what happened to the NHS when NHS England came along. And great for Wales that he disrupted it, but it's no good then combining the Department of Health and NHS England by halving the people, saving money, but it's the same culture. I don't know, Gordon, do you feel that, and Gordon, do you feel that clinically it's just...
Yeah, I have to say that, I think Amar must run one of the most advanced primary care facilities in the country. And it's great that you think of novel ways to do things and you introduce new technology. But fundamentally, you're still there looking after patients. And if you can't come up with a way to, to actually deliver this, then there's no GP practice that's going to manage to do that. I mean, Pat, you must be incredibly frustrated. With the radiotherapy funding that's mentioned in the plan was already agreed, wasn't it? There's no additional funding over and above that.
Don't get me started on radiotherapy. I will just, fortunately, we had a big do in Parliament yesterday about radiotherapy. And actually, the shadow health secretary was there. He got it. And in Parliament today, he stood up and questioned it. No, the issue with radiotherapy is, okay, I'll do this. Okay, I'll do my 2-second spoon, if that's okay. Needed in half of all cancer patients and involved in 40% of cures. So this is serious treatment. And it is actually, after surgery, it's the second most curable thing. So we need radiotherapy. Let's get that straight. Now, it has systematically been blocked so long, and yet the total workforce in radiotherapy to treat over 100,000 patients a year is 6,000. Wow. Right? You could increase that by a few. That wouldn't take much. Also, we know that of that workforce, they are extremely tech savvy, and there's lots of things you can do. But the trouble is, because of systematic underfunding, and we've been stopped doing what we want to do, we've been literally stopped doing what we want to do, it means that although, cancer weights having changed the targets a little bit are between 60 and 70%. Do you know what radiotherapy is as a treatment modality first treatment? Needing 40% of cures. It's 40%. In some parts of the country, it's 20%. How? Without any workforce changes or any investment in radiotherapy, and still with the blocks we have, how are you going to get that to 85% in 3 years? It's a miracle. And yet, what's depressing, the group together have put forward, when we had the 2000 plan, we had a National Radiotherapy Advisory Group, again, independent, working together, technical things, do this. Fantastic. We've said you need an NRAG too, because we've presented the Department of Health with the solutions, all the things we need, whatever, we could do this. What was in the plan? Nothing.
Wow.
And silly examples.
going against the
Yeah,
evidence
well,
that I
you're
said
right,
earlier
going
on.
against
So
the
the
evidence.
evidence, so it's essentially
Yes.
saying, Denmark, you do what you want, get a better outcome, but we're not going to do the same with you. We're actually going to do the exact opposite and have less radiotherapy and our radiotherapy machines that are not fit for purpose. I mean, if we look at the overall, sort of, the 10-year plan, for health in England, in relation to fit for the future, I don't think this is fit for the future for cancer. In fact,
Yeah.
it's
And
unfit for the future.
And if you think, Pat, when being in Cambridge and was heavily involved in the Cambridge IMRT study, import low, import high, the fast forward study, bringing radiotherapy, treatment to a much shorter time, huge advances, unbelievable advances, driven by really, really smart clinicians and scientists. And to not have that implemented, fully, is a great tragedy.
But you see how bad we are? There are people around the country where the waiting list for your breast radiotherapy is 6 months. We even had a patient come to Parliament. She said she was told it was 6 months, and then she was phoned up and said, well, as it's 6 months, do you really want it?
Wow.
And we also
just-
know of patients, because of the waiting list, people are just not having treatment. So although we say they're not having it fast enough, there are people not even having it at all. And I can't see, because also a radical course of radiotherapy, even with the good stuff, £7,000. So we cannot afford £7,000 for cure. If you knew it was that, you'd whip round with your friends, wouldn't you, and get the £7,000 to be cured. But people don't know this, and they don't know that they should be having this, and they don't know they could. Never mind the access. So anyway, I'll stop going on about radiotherapy, but that was an own goal that was unbelievable. And also, if you've got radiotherapy needing 40% of cures, if it's down at 20% in some places, you are never going to get the total waiting lists up to 85%. You just physically can't do it. So they're automatic. Unless they do something about radiotherapy, you are going to fail in 2029 completely. So how does that make sense?
I mean, it's disappointing because we have great people. I've got great colleagues across the 4 nations of the UK, but we're not in the room.
Yes, actually, Mark, talking about across the 4 nations, may I say, Northern Ireland, your weights are pretty bad. I remember being on Radio Belfast at some time, and at one point they were down at 29%, which I would say is not a cancer service.
Wow.
Yeah.
That's a routine service.
I agree. I invited a lot of our Northern Ireland MPs along to the Radiotherapy UK event yesterday and pointed out to them, this is what we need. We need to change this. Otherwise, we're going to be, I mean, we went from a situation from having the worst outcomes in the United Kingdom for pretty much every cancer to actually having for 15 years an actual similar to Mike Richards in the UK. We had a very sort of sensible CMO. And we improved, and we showed, for example, for breast cancer, we had the best outcomes in the UK. But now we're starting to drift back again. That's what really frustrates me, because we know we can do it. We've shown we can do it, but then things lapse because of changes or because of lack of, courage, really, to say these need to be done. Cancer needs to be ring-fenced in this situation. Cancer is not, no matter what anyone says to you, it's not like other diseases, because it's something that you have to be keeping an eye on it, treating it over different periods of time. Cardiovascular disease, you diagnose it once, you see people on statins, that's it. I know that might sound slightly, but you know what I mean. I'm biased, obviously, but I'm just saying that when we had a situation where we actually, like, we were much better than we are now. So that's ridiculous, because we should be always improving.
Yeah. So trying to end this podcast on a note of hope. I'm just going to go one by one. If there was, give us your elevator pitch. Can we rescue this? Can we make it better, or is it too late? And if there is something that I know that you've already had the ear of words, but one policy suggestion or one, suggestion about changing culture, what would you say to Wes or Stephen Kinnock when Wes becomes Prime Minister?
God, I would say what I said on the TV yesterday. I'd said, whereas you need to get the clinicians in like tomorrow and talk to the people who know what to do, how to do it, let them get in there, get the barriers out of the way, get the bureaucracy away, and absolutely take this seriously. But that will remain a culture change and a change. You've got world-class frontline staff. You
still,
could do it, but if you don't talk to the clinicians and put them in that driving seat or talk to the experts, no chance.
no. Gordon.
Well, as I said earlier, I think I'd like to see lung and prostate cancer screening rolled out as quickly as possible, hopefully with support from the National Screening Committee. I think if we do that, we will definitely improve early cancer detection for the 4 cancers that currently cause the majority of cancer deaths in this country. And for every stage shift we can go in the right direction with screening, then we save a lot more money that we will then have to spend on all the other things that we would like to do that will increase the user experience. So it will also give us some quick wins, and it might start dialing up the early cancer detection rate. So that would be my focus, some targeted funding to get quick wins.
Brilliant. Mark.
I have no doubt that West Streeting wants to try and solve this problem. He's passionate about it. He's spoken well about it, and he certainly wants to make a difference. I think what he needs is people to help him with the implementation. We can live with some of the aspirations. Obviously, some of them we don't agree with them, but the critical thing now is how do we implement? And I think if he sort of lets the people who actually know how to do implementation help him, we can actually avert what is going to be a cancer crisis. It's going to be a cancer pandemic if we don't do something about it now.
Absolutely. Thank you all for joining us tonight. I thought it was a really important thing that we get out, because people don't know the state of cancer services, and I think people deserve to know, and I think people need to be mobilized to actually speak out and contact their MPs to push this forward, to give cancer the attention that it deserves, because it's going to affect so many of us and it causes so much suffering, and it should be a priority, just like we prioritize the pandemic, with the cancer crisis that's coming up, that everyone knows that it is there, all the people that are in the know. We need to do something about it, and we need to start acting now. So please
Cancer's
do
killed a
write
lot more people than COVID, and we'll continue to after COVID. It's not killing anybody anymore. So that's
And
key.
also, we do know what to do.
Yeah.
We do have some treatments. We just have to organise ourselves to give them on time.
Absolutely. On that note, we are going to do another hot take in the future, and we're going to hopefully get some of you to come in and talk to us about different forms of cancer, so that we can get the message out to our patients as well. So thank you all for watching, and see you later on. Take care. Bye.
Bye.
Bye, everybody.